everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular session, I'll be discussing a very important topic, that is Aspergillosis. So if you take this Aspergillus, right, we have the various species of the Aspergillus. That includes the Aspergillus fumigatus and as well as the Aspergillus niger. Now, what we are interested in the discussion in the present session is mainly about the pulmonary aspergillosis. So, if you take this Aspergillus fumigatus is the one which is responsible for pulmonary aspergillosis. Whereas, if you see this Aspergillus niger is the one which is responsible for the development of external ear infection, and which is nothing but fungal otitis media. Right, so this fungal otitis media, it is nothing but your external ear infection. Alright, so now let me discuss in detail about the pulmonary aspergillosis. Let me tell you, this pulmonary aspergillosis or Aspergillus fumigatus, it is not a highly contagious disease. And in which group of individuals these fungal infections are very common? Please remember, the fungal infections, they are very common in severely immunocompromised patients. Right, so in severely immunocompromised patients, these fungal infections are very common. Now, if you take this pulmonary aspergillosis, which is caused by Aspergillus fumigatus, this pulmonary aspergillosis, it has 4 forms. And these 4 forms of pulmonary aspergillosis, it includes ABPA, that is Allergic Bronchopulmonary Aspergillosis, then Aspergilloma, right, or it is also called saprophytic aspergillosis. And the next important form of pulmonary aspergillosis include chronic necrotizing aspergillosis. Right, chronic necrotizing aspergillosis. And the 4th important form of pulmonary aspergillosis is invasive aspergillosis. And this invasive aspergillosis, it is the severe form of the pulmonary aspergillosis, and it is seen mainly in severely immunocompromised patients. So this is about your pulmonary aspergillosis, which has the 4 forms. Now, out of which, let me discuss in detail about the ABPA, that is Allergic Bronchopulmonary Aspergillosis. So Allergic Bronchopulmonary Aspergillosis, as the word itself tells you, it is allergic. So it is a pulmonary hypersensitivity disorder. Right, it is a pulmonary hypersensitivity disorder. And when I am using this word pulmonary hypersensitivity disorder, what does that mean? It is the disorder which is caused by allergy to fungal antigens. Right, it is caused by allergy to fungal antigens. And where will these fungal antigens being present? These fungal antigens, they colonize in the tracheobronchial tree. right? They colonize in the tracheobronchial tree. And this ABPA, that is Allergic Bronchopulmonary Aspergillosis, it most commonly occurs in atopic asthmatic individuals. Right? It most commonly occurs in atopic asthmatic individuals. And this allergic bronchopulmonary aspergillosis, it occurs in response to antigen of the Aspergillus species. So, in a nutshell, ABPA, it is a hypersensitivity disorder. It is caused by the fungal antigen, right? Caused by allergy to fungal antigen that colonizes in the tracheobronchial tree. And most commonly it is seen in atopic asthmatic individual. And this ABPA, it has the primary or main diagnostic criteria to diagnose ABPA, and then we have the minor diagnostic criteria. Now, let me tell you what are the main diagnostic criteria. The main diagnostic criteria is that the individual should have the clinical history of asthma, right? And that too, what type of asthma? Atopic asthma. See, asthma, it is of two types. One is atopic and the other one is non-atopic asthma. So, the main diagnostic criteria is that there should be history of atopic asthma, and it is a hypersensitivity disorder. So, you have a eosinophilia, because in any of your allergic reactions, the cells which get elevated in the peripheral blood picture will be peripheral eosinophilia. And then followed by that, there will be also presence of pulmonary infiltrates. And these pulmonary infiltrates, they are also secondary to allergic reactions to the fungus, that is Aspergillus. Now, because it is an allergic event, so if you do a skin sensitivity test to Aspergillus antigen, it will be positive. So, there will be immediate skin reactivity to Aspergillus antigen. And hypersensitivity disorder, allergic reaction means which particular antibodies that has to be elevated? There will be elevated IgE levels, right? There will be elevated IgE levels. And in these patients, they also develop what is called as bronchiectasis, and that will be your central or proximal bronchiectasis. That is what you will observe in patients with the allergic bronchopulmonary aspergillosis. Bronchiectasis, right? It is an obstructive lung disease which is characterized by abnormal permanent dilatation of the medium-sized airways, and that particular airways will be from 5th to 9th generation. So that is your main diagnostic criteria in patients with the allergic bronchopulmonary aspergillosis. Now, so this will be the immediate skin sensitivity test, that will be positive, and you have the presence of bilateral infiltrates. Now, what are the secondary diagnostic criteria? So we have primary or main diagnostic criteria and secondary diagnostic criteria. So in the secondary diagnostic criteria, please remember there will be history of brownish plugs in the sputum. Right, history of brownish plugs in the sputum. And the second important secondary diagnostic criteria will be identification or culture of Aspergillus fumigatus from the sputum. Right, identification of Aspergillus fumigatus from sputum. And third important, elevated IgE class antibodies specific for the Aspergillus fumigatus. So this elevated IgE, it is also the part of main diagnostic criteria, and it is also part of the secondary diagnostic criteria as well. But what is the difference? The level of increase. If you take in case of the main diagnostic criteria, there will be excessive elevation of IgE levels, but whereas in case of the secondary diagnostic criteria, the elevated IgE class antibodies are specific to the Aspergillus fumigatus, right? And this will be the color of the sputum, what you will see in patients with allergic bronchopulmonary aspergillosis, and the presence of your brownish sputum will be your secondary diagnostic criteria. Next, if you see the question here, all of the following are true about allergic bronchopulmonary aspergillosis except central bronchiectasis, pleural effusion, asthma, eosinophilia. So, we have discussed main diagnostic criteria and as well as secondary diagnostic criteria. You take the presence of the central bronchiectasis, that will be your primary or main diagnostic criteria. Presence of atopic asthma, that is also the primary or main diagnostic criteria. Presence of eosinophilia, because it's an allergic disorder, it is a main diagnostic criteria. But pleural effusion, let me tell you, it is not seen in patients with the allergic bronchopulmonary aspergillosis. Please remember, this is a very important point. And what do you understand by this word pleural effusion? It is a disorder where you have the presence of excess pleural fluid in the pleural space is what is called as pleural effusion, and you will not see that in patients with the allergic bronchopulmonary aspergillosis. Now, if you see the clinical features in these patients with the ABPA, so what is the presentation? That will be in the form of dyspnea, right? That will be in the form of dyspnea, right? Where the individual will have difficulty in breathing. And on examination, you also have the presence of wheeze, because it is seen in those individuals with a history of atopic asthma, right? So ABPA, it causes episodes of wheezing, right? ABPA, it causes episodes of wheezing, and there can be also presence of low grade fever, right? Then followed by that, there will be brownish or greenish flecks in the sputum. Right? Brownish or greenish flecks in the sputum. Okay, and apart from that, if you take the investigations in patients with the ABPA, as already we have discussed, there will be presence of the pulmonary infiltrates in the chest X-ray, right? There will be presence of pulmonary infiltrates in the chest X-ray, and there will be also eosinophilia. Right, there will be also presence of eosinophilia, right? The sputum and as well as the blood eosinophilia. And in patients with ABPA, there should be history of pre-existing asthma, that is atopic asthma, and cystic fibrosis. Okay, ABPA, it occurs in patients with pre-existing asthma and as well as the cystic fibrosis. If you see the complications of the ABPA, complications of ABPA is that patients with repeated exacerbations, they develop central bronchiectasis. Okay, so in those individuals who have repeated exacerbations, they develop central bronchiectasis, right? Central, or which is also called proximal bronchiectasis. That means the bronchiectasis is mainly confined to the upper lobes, and the other important complication with repeated exacerbations is there will be progressive loss of pulmonary functions. What is the important pulmonary function? That is the exchange of gases. So there will be loss of the pulmonary function. And ABPA, please remember, it mainly involves the upper lobes. Right? It mainly involves the upper lobes. Right? And it is not the involvement of the lower lobes. right? ABPA, it mainly involves the upper lobes but not the lower lobes. And the involvement, ABPA lesions, they are bilateral. Right? ABPA lesions, they are bilateral and they tend to occur more frequently in the upper lobes. And please remember, pleural effusion is not seen as a part of the allergic bronchopulmonary aspergillosis. Now the next question is, how is this human aspergillosis being spread? So if you see the mode of spread of this human aspergillosis, it most commonly results from the inhalation of conidia, right? Inhalation of inhalation of the conidia, and it is not a contagious disease. Right? It is not a highly contagious disease. And nosocomial infections may occur among hospitalized and immunocompromised patients. Right? So the spread can be seen even within the hospital, mainly in the immunocompromised patients. Next, if you see, the next important thing is, okay, let me just summarize the diagnostic criteria now. So if you take the diagnostic criteria, we have main and as well as the secondary diagnostic criteria. Main diagnostic criteria, atopic asthma, pulmonary infiltrates in the chest X-ray, peripheral eosinophilia in the blood, there will be skin sensitivity test will be positive, and the serum precipitants will be elevated for the Aspergillus fumigatus, and there will be elevated IgE levels, and there will be also central bronchiectasis. So these are the main diagnostic criteria. Secondary diagnostic criteria, right? History of brownish plugs in the sputum, culture of Aspergillus fumigatus will be positive in the sputum, elevated IgE which is specific to the Aspergillus fumigatus. So this is the summary of your diagnostic criteria, and this is the chest X-ray of patients with the ABPA. So what does this chest X-ray shows? The presence of mainly the involvement of the upper lobes. Okay, so predominant upper lobe involvement will be there. And this upper lobe involvement, it is seen in almost 50% of individuals, bilateral upper lobe involvement. And the individual will have fleeting alveolar subsegmental or lobar infiltrates. So fleeting in the sense, these infiltrates, they shift from one area to the other area. So there will be fleeting alveolar subsegmental or lobar infiltrates. Right? And the third important thing is, these shadows, they move around the upper part of the lung. Why am I using this word fleeting? Because these shadows, they move around the upper part of the lung. Right? They move around the upper part of the lung. And the chest X-ray, it also shows the picture suggestive of bronchiectasis. Right? The chest X-ray. And what will be that picture suggestive of bronchiectasis? That we call it as tram track appearance. Right? Tram track appearance. So mainly it will be central bronchiectasis. So this will be the chest X-ray picture in patients with the ABPA, that is Allergic Bronchopulmonary Aspergillosis. Now, followed by that, the next important, like what we have is the diagnosis of invasive aspergillosis. So I said you, like one of the form of your aspergillosis is the invasive aspergillosis. This invasive aspergillosis, definitive diagnosis require demonstration of aspergillus in the tissue or culture, right? So, invasive aspergillosis, you should be able to demonstrate the Aspergillus fumigatus in the tissue, right? That will be the definitive diagnosis. So, demonstration of Aspergillus fumigatus in the tissue or culture from a sterile site. Now, that will be your definitive diagnosis. Now, apart from this, right, apart from this, we have certain indirect diagnostic assays, and these indirect diagnostic assays, if you see, so these indirect diagnostic assays, they include detection of Galactomannan in bronchoalveolar lavage. Right, detection of Galactomannan in the bronchoalveolar lavage, or the serum assay for 1,3-beta-D-glucan will be elevated. But remember, this 1,3-beta-D-glucan, which will be elevated in patients with the allergic bronchopulmonary aspergillosis, it is not specific for Aspergillus, right? It is not specific for Aspergillus. Okay, so this is how you will diagnose invasive aspergillosis. For invasive aspergillosis, definite diagnosis require demonstration of Aspergillus in tissue or culture from a sterile site. And we also have indirect diagnostic assays that include the detection of Galactomannan in bronchoalveolar lavage fluid, or the serum assays for 1,3-beta-D-glucan that will be elevated. But this elevated 1,3-beta-D-glucan, it is not specific for the Aspergillus. And in case of invasive aspergillosis, if you see the CT scan, right, this is a very important multiple choice question. A common radiological finding include the presence of the nodules, right, the presence of the nodules, and there can be also presence of wedge-shaped infarcts. Right, there can be also presence of wedge-shaped infarcts or a characteristic halo sign, right? So you can consider, right, this is your halo sign. So this is a very important multiple choice question. The presence of halo sign is characteristic feature of the invasive aspergillosis. And what is this particular halo sign? It is a zone of diminution of ground glass opacity, right? It is a zone of diminution of ground glass around a consolidation. So that will be your halo sign. Now, after having discussed about the diagnosis of ABPA and as well as invasive aspergillosis, let me just show you one important clinical question. So that includes the following. We have a 40-year-old patient with history of prolonged exposure to the allergic substance, right? Prolonged exposure to the allergic substance. Chest X-ray shows the presence of diffuse pulmonary infiltrates. Skin hypersensitivity test is positive for Aspergillus antigen. Peripheral blood shows normal eosinophil count and serum IgE levels are also normal. What will be the most likely diagnosis? The options are allergic bronchopulmonary aspergillosis, allergic bronchial asthma, extrinsic allergic alveolitis, invasive pulmonary aspergillosis. Now, so the question is very clear that the individual has the hypersensitivity reaction for the Aspergillus, right? Hypersensitivity reaction to Aspergillus. So this hypersensitivity reaction to the Aspergillus, it is of two types. One is IgE mediated and the other one is non-IgE mediated, right? I said you that whenever the individual is exposed to Aspergillus antigen, one form of aspergillosis already just now we have discussed, ABPA, that is Allergic Bronchopulmonary Aspergillosis. So, Allergic Bronchopulmonary Aspergillosis, it is seen in individuals with atopic asthma, where the IgE levels are elevated, right? Where the IgE levels are elevated. And even you take in patients with atopic asthma, the IgE levels, they are elevated. So, hypersensitivity reactions to Aspergillus, please remember, it is IgE mediated and it is seen in atopic individuals. So, either you take in asthma or you take in patients with allergic bronchopulmonary aspergillosis, the IgE levels are elevated. Then followed by that, we have non-IgE mediated. It is the same hypersensitivity reaction to Aspergillus, but it is non-IgE mediated. So, it will be your non-atopic individuals, right? It is your non-atopic individuals. So, non-IgE mediated will be extrinsic allergic alveolitis. So, in extrinsic allergic alveolitis, please remember the IgE levels are normal. Right? So, please remember this point, the IgE levels are normal. Whereas, in case of IgE mediated, the IgE levels are elevated. So, if you go back to the question here, what will be the answer? The answer is extrinsic allergic alveolitis. So, don't be under the impression that when the individual is having skin hypersensitivity positive for the Aspergillus antigen, don't be under the impression that it is directly ABPA. If the IgE levels are normal and there is a history of exposure to the Aspergillus, you need to consider extrinsic allergic alveolitis. So, now let me discuss the features of extrinsic allergic alveolitis. First and foremost, very, very important, these individuals, they have normal IgE levels. Right? Next, there will be absence of the peripheral eosinophilia. Then, third important point is there should be diffuse pulmonary infiltrates on the chest X-ray. Right, there should be presence of diffuse pulmonary infiltrates on the chest X-ray. So these are the points suggestive of extrinsic allergic alveolitis. So the very important difference between ABPA and extrinsic allergic alveolitis is about the IgE levels and as well as the eosinophils. In ABPA they are elevated, whereas in extrinsic allergic alveolitis they are within the normal limit. Now let me discuss the treatment of the aspergillosis. So if you see the treatment, mainly in case of the allergic forms. In allergic forms of the aspergillosis, the drugs what we give is an antifungal drug and as well as it is an IgE mediated. It's a hypersensitivity reaction. So you need to give corticosteroids to reduce that particular hypersensitivity. So now what will be the antifungal drug that we administer? That includes Itraconazole. Right, that includes the Itraconazole. So the Itraconazole, it is the best studied agent for the treatment of allergic Aspergillus sinusitis and also in allergic bronchopulmonary aspergillosis. And along with this, you also need to add the corticosteroids. Right, so these corticosteroids, they play a very important role, right, and they are considered as the cornerstone of therapy for ongoing care. For suppose, this will be like the maintenance therapy. If the individual has a superadded acute exacerbations, right, if the individual has superadded acute exacerbations of ABPA, in such case, you need to give oral prednisolone. Right, you need to give oral prednisolone. And this oral prednisolone, it is given at a dosage of 0.5 milligrams per kg per day. Right, so this will be the dosage of the oral prednisolone. And then gradually it has to be tapered over several months. And if you take the dosage of the Itraconazole, it is given at a dosage of 200 milligrams orally daily for 16 weeks. Okay, 200 milligrams daily, and it has to be given for nearly around 16 weeks. And when you give this 200 milligrams daily for 16 weeks, this will improve the pulmonary function of the individual. And whenever you are giving this Itraconazole, supplementation of Itraconazole will decrease the steroid requirement. Right, will decrease the steroid requirement in these patients. And apart from the Itraconazole, the alternative agent is the Voriconazole. Right, the alternative agent will be Voriconazole. So that will be the treatment in case of allergic forms of the aspergillosis. Then we have a clinical entity called chronic aspergillosis. See, in chronic aspergillosis, the individual can have invasive aspergillosis and there will be development of aspergilloma. So please don't get confused here. Aspergilloma is mainly seen in those individuals with invasive aspergillosis, and that too in chronic condition. So in those with aspergilloma, you need to do surgical resection. Right, you need to do surgical resection. And other forms of chronic aspergillosis are generally treated with oral azole therapy. If it is like aspergilloma, you need to do surgical resection. But if it is other forms of, right, if it is the other forms of the chronic aspergillosis, they are generally treated with at least 4 to 6 months of oral azole therapy. Right, 4 to 6 months of oral azole therapy. And that particular azole will be Itraconazole. And this Itraconazole, it is given at a dosage of 200 milligrams. You have to give it daily, and that too twice daily. That will be your Itraconazole. Then followed by that Voriconazole. So Voriconazole, if you see, the dosage will be 200 milligrams twice daily. Or the other important drug like what we have is posaconazole. And the dosage of this posaconazole in case of chronic aspergillosis will be 300 milligrams daily. Okay, so 4 to 6 months oral azole therapy has to be given in case of the chronic aspergillosis, right? And the data, and right, if the question is asked, like among all these particular drugs, which is superior? So Voriconazole therapy, it is found to be superior to Itraconazole for maintenance therapy, right? Voriconazole, it is considered as superior to Itraconazole mainly for mainly for the maintenance therapy. Next, so we have discussed the treatment of allergic bronchopulmonary aspergillosis. Second, the chronic aspergillosis. If it is aspergilloma, surgical resection, and if it is like the other forms of chronic aspergillosis without aspergilloma, you need to give oral azole therapy. Whereas you take in case of invasive aspergillosis, so your aspergilloma formation and as well as invasive aspergillosis as well as the chronic aspergillosis. So your aspergilloma formation will be in between your chronic aspergillosis and invasive aspergillosis. So what will be the exact treatment for your invasive aspergillosis? So the data from 2017 European Society for Clinical Microbiology and Infectious Diseases have shown that for invasive aspergillosis, we have to give a very important alternative, we have to give a very important antifungal drug, and that will be Voriconazole. Right, so that will be the very important antifungal drug, right? That is Voriconazole. What is the dosage of this drug? That is around 200 ml. That is around 200 milligrams. It has to be given intravenously every 8th hour. Right, 8th hourly. That is for almost 6 doses. Right, that is for almost 6 doses. Then you need to taper to 200 milligrams daily. So for invasive aspergillosis, please remember the drug of choice will be your Voriconazole, or we have another drug that is Voriconazole. This also can be considered as the first line therapy, right? This also can be considered as the first line therapy. Next, now apart from the Voriconazole, we have another randomized control trial which has been done on a drug called Anidulafungin. Right, we have another drug called Anidulafungin. So this Anidulafungin, it is mainly effective in those individuals where Galactomannan was detected. Right, this is a very important question. So in those individuals where Galactomannan was detected, in these individuals, the Anidulafungin was very much effective. And what will be the dosage of this Anidulafungin? The dosage of this Anidulafungin is 200 milligrams on day 1. Then followed by that, you should give 100 milligrams daily. Right? So that will be the dosage of this Anidulafungin. And in those individuals who have received Anidulafungin along with Voriconazole, this particular combination was found to be effective. Right? Who received combination therapy, the outcome was better. Now, for those individuals with Galactomannan was detected, we give this combination, and we also have the alternative drugs as well, right? The alternative drugs include number 1, amphotericin B, and that too liposomal right, that is your liposomal amphotericin B. And this liposomal amphotericin B, it is given at a dosage of 3 to 5 milligrams per kg per day. And other drug is caspofungin. This caspofungin, it is given at a dosage of 70 milligrams intravenously on day 1 and then 50 milligrams per day thereafter. And the other alternative drug will be micafungin, right? And the other alternative drug will be posaconazole. So this will be the treatment in patients with invasive aspergillosis where galactomannan was detected, right? So let me just summarize the treatment now. So in case of allergic forms of aspergillosis, you need to give a combination of itraconazole and as well as steroids. If there is acute exacerbations, you need to give prednisolone at a dosage of 0.5 milligrams per kg body weight. And in those individuals, apart from itraconazole, the other alternative agent will be voriconazole as well. And in chronic aspergillosis, with aspergilloma, surgical resection has to be done. And in other forms of chronic aspergillosis, you need to give oral azole therapy. That is itraconazole, voriconazole, and the other important drug is posaconazole. And for maintenance therapy, voriconazole is superior to that of your itraconazole. And in case of invasive aspergillosis, the drug what has been studied is isovuconazole, and this should be given along with the voriconazole, right? The alternative will be your voriconazole. And in case of the individuals where the galactomannan was detected, the ideal drug will be anidulafungin. This anidulafungin should be given along with the voriconazole, where the outcome was found to be better. And the other alternative agents will be liposomal amphotericin B, right, caspofungin, micafungin, and then posaconazole, right? So this will be the treatment for your invasive aspergillosis. Next, now about the surgical debridement. Surgical debridement, let me tell you, it is generally done for sinusitis, right? It is generally done for sinusitis, and it can be useful for focal pulmonary lesions as well. Right, useful for focal pulmonary lesions, especially for treatment of life-threatening hemoptysis and infections refractory to medical therapy. We do this surgical debridement, right? So when there is life-threatening hemoptysis and infections refractory to medical therapy, in them we do this surgical debridement. And how is the mortality rate? See, mortality rate of pulmonary or disseminated disease in immunocompromised patients, it is very high, right? Because as such the fungal infections are very common in immunocompromised patients. So the mortality rate will be very high, right? And it is high in individuals with severely immunocompromised condition, and in those individuals with refractory neutropenia, in them also the chance of mortality is very high. So this is about your aspergillosis. And the next thing like what we will discuss is, we will discuss few questions on this topic of the aspergillosis.